people would just drop dead.
Got it. From heart attacks, right?
From a heart attack. And the Widowmaker is a specific vessel. They call it that because it happens very frequently and is one of the most deadly things that you can go through. Welcome to the Nurse Multiverse podcast. Today we're going to be covering cardiopulmonary and peripheral circulation. All right. So quick definition to kind of understand what we're talking about. One of the words that I want you to learn is called peristalsis. And what peristalsis is successive waves or involuntary contraction. And this is done by the smooth muscle. That takes us to another definition that we're going to talk about, which is the types of muscle in your body. You have the skeletal muscle, your bicep, your tricep, and you can move it voluntarily. And then you have two types of muscle that you move involuntarily. What that means is they just move by themselves, obviously. And that is the cardiac muscle and the smooth muscle. Since we're talking about arteries and veins, we are going to be talking about smooth muscle in these places. All right. We are going to start now. We're going to talk about the differences between arteries and veins. Okay. So the pressure on the arteries is high. It's a high pressure system. The veins is a low pressure system. The wall thickness of the arteries is thicker than the veins. The lumen diameter is narrow on the arteries because it's a high pressure system and wide in the veins. And the wall layers, this is the important part. Both arteries and veins have 3 layers. The only difference is in the tunica media, and the arteries is very thick and in the veins is very thin.
What is the tunica media?
So you have 3 layers on arteries and veins. You have the tunica adventitia, which is just the outer layer.
So the tunica is like a name for like a layer?
Yes. Tunica? Yeah. So these are the veins, the way that they're wrapped up is 3 different layers for different things. The adventitia is for protection and anchorage. The media is what makes the peristaltic movement that we were talking about. And it's a strong peristaltic movement in the arteries and a weak peristaltic movement in the veins, because in the veins is a thinner layer of smooth muscle. And finally, you have the tunica intima, which is the innermost layer of these vessels, this vasculature. The other one that we're going to go over, muscle and elastic fibers. Large amount in the artery, low amount on the vein. And finally, valves. Arteries do not have valves and veins have valves. And we're going to talk a little bit about that. If you want to always remember what the arteries do versus the veins, the keyword is A for artery, meaning away. And if the artery is moving away, then you're going to know that the vein is moving towards. And in relation to the heart is what we're talking about. So veins carry blood to the heart and arteries carry blood away from the heart. The way that veins move the blood back to the heart is composed of 2 things. One, the peristaltic movement of the tunica media. And number 2, the one-way valves that are lined up on the veins, meaning that blood only moves forward, it can't move back. And we're going to be talking about one-way valves when we cover heart circulation. So that's it for peripheral circulation. Your vasculature is, how it functions. Just keep on to remember, artery means away, and the arteries carry blood to the organs. Vein moves the deoxygenated blood back to the heart and the lungs. Any question, Jay? No? Okay, good. So we're going to quickly move on to heart and lung circulation. The definitions that we're going to be talking about here include diastole. During diastole, the ventricles relax and they're filled with blood coming from the atria. Then systole.
Blood coming from the where?
So if you look, you have the right and left atrium, and then you have the right and left ventricle. So during diastole, the right and left atrium fill with blood, and then during systole, they fill with blood on these one-way valves right here.
And for the people that are just listening, that are not looking, where would those valves be at?
So the valves are connecting the right atrium with the right ventricle and the left atrium with the left ventricle. And the way that the blood travels, it travels from atrium to ventricle, not the other way.
Okay.
So there's a pair of one-way valves in the atrium, on both atriums, leading to the ventricles. All right. So what we were saying, so the ventricles relax and they relax and they fill with blood coming from the atria via these one-way valves. And once they get full, then they contract. When they contract, the left ventricle sends the blood through another one-way valve. It sends it to the body. And when the right ventricle contracts, it sends the blood towards the lungs via the pulmonary arteries. All right. So we're just going to cover this in sequence so you understand. The right atrium, blue blood returns to the heart via the veins. So your veins bring your blood back to your heart. They go through the one-way valve into the ventricle. And then the ventricle, what it does is sends blue blood to the lungs via pulmonary arteries, via a different one-way valve. After the lungs, the red blood returns to the heart via the pulmonary veins through the one-way valve that we're talking about. And then the ventricle contracts and it sends the red blood to the body and the organs via the arteries. Specific regarding to the heart, pulmonary veins in the heart, they transport red blood back to the heart. So people get confused sometimes because when you're looking at general circulation, the arteries take blood to the organs. When you're looking at heart circulation, the veins are taking the red blood to the organ, to the heart itself. And pulmonary arteries move blue blood from the heart to the lungs. So it's flip-flopped. Another thing to remember is when you look at this on the notes, you have to flip it like this.
Well,
anyway,
what are you?
A lot of people get confused because they look at this and they think that the right ventricle, it's on the opposite side and the left ventricle is on the opposite side. Maybe not everybody makes this mistake, but I used to get confused with that. So I would always have to pick up the book and transpond it to realize left and right.
Okay.
And so that pretty much concludes what we're talking about. Just try to make it real simple, real functional. That's why I don't like to draw the heart like anatomically correct. I like to put boxes because I feel like it helps people a little bit more to understand circulation in general. And the heart is a pump just like a hardware pump. It's nothing more
when you say the heart is a pump like a hardware pump, what do you mean by that?
I'm talking about plumbing, basically.
What do you mean by, like, how does that apply to the heart?
Well, the way a pump receives liquid and it pumps it out, there's the same thing with the heart. The only difference it maybe will be, I don't know if in plumbing there's one-way valves or not, but I think there are. Yeah. So basically the body is made with this kind of terms that are similar. The heart is controlling the blood that's going to get oxygenated, and it pushes out the oxygenated blood. And throughout the body, these vessels act just like pipes in a plumbing job, where the veins have one-way valves because they're not strong enough to bring the blood back just by themselves. And the arteries are more narrow and they have a higher pressure in order to travel down.
So the narrower the lines, the more pressure there's going to be?
Yes, and that's a plumbing concept too. Then more the smaller the lumen diameter of a pipe or your vein, it's the same. The smaller, you're going to have a higher PSI.
And how would that apply to what you explained about the?
Yes. So, for example, it's very easy. The beginnings of hypertension. It could cause by a narrowing of the arteries, which happens with, for example, easy sample, with cholesterol. Cholesterol starts thickening the walls of the artery more, which in turn raises your blood pressure. So then the left ventricle is trying to push against that resistance. So basically the left ventricle is trying to push against the resistance of the artery itself. Past a certain threshold of pressure, the blood starts backing up in the left ventricle. And that's when you talk about left ventricle hypertrophy, which is heart failure.
So the left is what pushes out and the right is what receives?
The right is receiving non-oxygenated blood via the veins, which is a low pressure system. So
where does the non-oxygenated blood come from?
It comes up from the veins. So basically, the heart pushes out the oxygenated blood. The arteries go down to the body and all the organs. And then via capillaries, which are very, very small veins and arteries.
So it's after the blood has been used by the organs?
Yes. Then it goes back into the vein. The vein brings it up to the right atrium. Then it moves to the right ventricle.
Why is it not oxygenated? It's because the organs have used up the oxygen?
Yeah. Okay. Yeah. So basically the organs are taking the oxygen away from the blood at that point. And once that cycle is done, the blue blood comes back up to the heart, goes to the lungs, back to the heart.
Why do you call it blue blood?
To me, deoxygenated, oxygenated, it just messes with my accent. So if I say red blood.
So the oxygen changes the color of the blood? It
actually does. It doesn't make it blue. But arterial blood is bright red and venous blood is dark red.
Oh, since it's dark red, they call it blue.
Yeah. Okay. In reality, I'm not familiar with this, but there's certain light, or there's some phenomena that it makes the blood look blue. But I'm not. It's not coming to us over.
Okay, no problem.
So I was talking about hypertension.
Yes.
So let's remember, arteries are a high pressure system, veins are a low pressure system. So what happens is the first part of the heart that starts getting overworked is the left ventricle, because the left ventricle is sending blood to the body. If you have narrow veins, that means that the pressure if you have narrow arteries, that means that the pressure within those arteries becomes greater. So then at some point of pressure, the left ventricle is going to start growing. And the thing with smooth muscle, the difference between smooth muscle and skeletal muscle is smooth muscle, the larger it gets, the more weak it is. It's supposed to have a certain size. If it starts growing past a certain point, this is when we have the issue with ejection fraction. So ejection fraction is how much the heart is pushing to the body. All right. So this is the first place to crap out. It grows and then it can't push hard and it starts quivering.
On ejection fraction, that would be it?
Well, the ejection fraction is basically how much blood the left ventricle is pushing to the body.
Okay.
So it could be 80%, 30%.
All right.
You know,
How is that? How's that calculated? How's that? Like, how do you find that out?
you got me there. I need to look that up and tell you later. I'm not well versed with every term in cardiology. There's certain things
Understood.
that I'm more that I'm better at than others.
Understood. Right, it's not your specialty, right? Your specialty is working more with
vascular.
the vascular, right?
So
the vascular system.
I'm more worried about keeping access on the patient, starting access on the patient, and all of those little things. I'm super specialized on that. So my cardiac knowledge is okay.
Right.
But it could be better.
100%.
So where we left it off. Okay, yeah. So the left ventricle is going to fail first.
Yes.
Once the left ventricle fails, then that pressure backs up all the way to the veins. Backs up to the right ventricle. And then when that happens, you need a heart transplant.
Okay. What happened? So the heart is exerting pressure, but the lines
it's pushing against pressure.
It's pushing against pressure. So it's basically like if you have a pump operating against a closed valve. Like
yes, but when in a healthy heart, the valve is opening.
The valve is opening.
Yeah.
Right.
On a sick heart, the valve
it doesn't open.
It's no. What is happening is it can't open or close normally because there's too much pressure in the system. Okay. So it's kind of doing this.
Okay.
This is when once you are on heart failure D, that requires.
That's from
the last podcast when we were talking about ventricular assist devices. What a ventricular assist device does is they make a hole on your right ventricle. They pump in there, and it deloads the left ventricle, so the left ventricle can beat.
Okay. Can you point out again? You don't have to do it on the paper, but can you point out like on your body which is the right, like which way with the right ventricle and which way with the left?
So my heart is going to be right here.
Okay.
This is my left ventricle. This is my right ventricle.
Right. Got it. And for the people listening, the left ventricle will be located towards your right arm.
When you're looking at notes,
right.
When you're looking at a drawing,
right,
the right ventricle is going to be on the left side and the left ventricle is going to be on the right side, because that's how anatomical
you're
models
looking at
work.
A drawing. But in actuality, the left is on your.
The left is on your left and the right is on your right.
Okay, just to understand.
Yeah. I always explain that. Maybe I'm the only one that's had that problem, but when I used to study anatomy and physiology, a lot of times it would be hard for me to connect both things when I was looking in the paper, and I would pick up the model and put it against me to kind of figure out. It's like when people can't tell the right from the left. They know it, but they have to like extra think. So I like to give that explanation more because maybe there's somebody out there that has that issue like I did.
Okay.
So we were talking about the ventricular assist devices.
Yes.
So what it basically does is takes the extra fluid out of your heart, so it's not so swelled up, so it can actually beat more effectively, and it dumps the blood in your general circulation. So it's basically like a rerouting system. Like if you don't want the pipe to burst, you have to connect something there, take some of that load off, or you have to clean the pipe. And this is when you go to the cardiac cath. That's what they're doing. They're applying stents to different parts of your heart in order for that vessel to continue to work.
Okay.
They can become fully occluded.
How does the stem work? Is that like like additional valve to the vein? How does that work?
No. A stent.
Stent? I'm sorry, that's a stem. Okay.
I'm like, okay,
it's
so
like what are you talking about?
I'm trying.
Okay, so what is it? A stent?
All right, so a stent. A stent is basically
STENT. Is that it?
Yeah.
Okay.
So a stent is basically I don't know what they call it in plumbing, but when you have to put hardware inside of the pipe to take away of the any debris that's there, basically it goes in flat into the vessel itself, and then it opens.
Okay.
All right. And the way it does it is kind of like when it's flat, it's like this.
Okay.
The doctor inserts it.
Okay.
And they widen it up by doing this.
Okay.
So if you look at what are those things that people use? The wire.
Wire what?
Like if you have a fence, but it's made out of wire instead of wood.
A wire fence?
A wire fence. Okay, so if you look at a wire fence, it has like the geometric design of a wire fence.
Yeah. Okay. Yeah. It's a square.
It's a square.
It's a square, but it's
like
at
an
diagonal.
angle.
It's like diagonal.
And you know why that is? It's because when they sell in bulk, they push this side of the square and it gets closed.
Okay.
In order to have more room.
Want some water?
Sorry, yeah.
Yeah, take some water.
It's not COVID. Anyway, so that's the same way that the stents work. And this Argentinian physician was the one that invented it in his garage.
Oh, yeah?
Yeah.
When did that happen?
Ooh, I will have to go back to that. There's a really good
infections.
There's a really good documentary that came out a couple of years ago. It's called The Widowmaker.
I see.
And he talks about that.
The heart attacks is
yes. There's a specific coronary artery.
What is his name? Julio Palmas? Is that it?
I think so.
Is this an interventional vascular radiologist?
Yep. That's him.
Is known for inventing the balloon expandable stent, for which he received a patent filed in 1985. Also, it's recent.
Yes. Yeah.
This patent has been included on the list of 10 most. Oh, okay. No, that's when they gave him the patent. Like maybe that's not when they meant.
Well, they give you a patent when you submit a design.
1986. Oh, so it's
what that means is he probably submitted the design in 1986.
Yeah, but this is the first stent.
But in order to use it, the first stent was used in 1986.
Yeah. Look, wow, that's interesting.
Yeah. So when they started doing those stents, they significantly increase patient outcomes for heart attacks. To the point where, like, if you have a heart attack now and we catch you on time, you're gonna be okay. There's like some of my patients were like smokers, and some of the patients will get up to 20 stents over 10 years.
Oh wow!
Yeah, so you can basically put as many stents as you can. Now, at some point, the stents are gonna stop working, and that's when you need an open heart procedure, where what they're doing there is the same thing. They're opening up the vessels, but they have to do it more invasively. They basically gotta split your chest open it there, open the heart, and insert vessels that are gonna circumvent the area that is obstructed. Does that make sense?
Yeah, no, that makes sense.
Okay, so that's what a open heart is. So the way that this progresses, and I hope it's not being too much information right now.
That's fine.
You have hypertension, your artery is narrow, you have a heart attack because the blood supply to the heart is compromised because of high pressure or weak beating, or your heart stops beating. They take you to the cardiac cath. They open up those vessels with the stents. They send you home. 10 years later, you have another heart attack. And at this point, the stents are not viable. So then at that point, they take you to the operating room and they do the procedure called CABG. That's the open heart. And usually when you get it, it's CABG times 3, CABG times 5. That's the amount of vessels that had to be circumvented by the surgeon.
So I am adding to the screen here
but Julio Palmas, that's not the main guy. There's another.
Okay, we'll look at.
We gotta look at it's just put the Widowmaker documentary.
Widowmaker. Oh yeah, but that's gonna show like a whole. That's not gonna show the information, right? It's gonna show like a whole documentary on it.
Not to show the documentary, but to show like what the Just in case people want to watch it,
Okay.
because it's really interesting. He talks about the beginnings of the modern stent.
All right. So we're showing this now. So you said look for it. What is it?
Widowmaker documentary.
Let's see what shows up.
If not, I can look it up. Let me see.
No, I can find it.
I'll race you.
Well, they're looking at this one.
That's fine.
Widowmaker documentary.
Yeah, it's called the Widowmaker.
This
2015. That one.
okay. And here they talk about.
That's when they talk about the guy that kind of came up with the modern stent.
Oh, okay. Got it.
And there's some controversy there because one of these cardiologists, he believed in doing CT scans to find calcification.
Mm-hmm.
So basically, your arteries, there's a number of ways that it can get narrow.
Mm-hmm.
It can get narrow because there's a clot there. It can get narrow because it's a cholesterol deposit there, or it can get narrow by a process called calcification. And what calcification does, it affects your smooth muscle, so the peristalsis don't work anymore, and blood starts backing up. Does that make sense?
Yeah.
Okay.
Oh, okay.
So yeah, so that's a really interesting documentary to watch. It's if you are into
what was your main takeaway from that documentary? From
just to learn and understand how they came up with the idea. And the main thing is this: there's a group of physicians that believe in doing CT scans and treating the patient accordingly, meaning they're gonna not try to put stents as much as they can, avoid it. And then you have the cardiologists that want to put stents on everything.
Mm.
And then in the middle you have the good people. But you have the two extremes, you know.
Does it become almost like a religion?
When you watch that, there's this Indian guy there that was for the stents, and then there's another guy that is not.
What?
And
like, but what's so?
it's a lot of money for procedure.
So do you know the reason? Do you know some of the reasons why they're for and against this?
Yeah. So there's the one side is saying to start with prevention earlier.
Mm-hmm.
If you are at risk, they put this machine in your legs and in your arms to help the circulation. Like indirectly, it's affecting how your left ventricle is working, right?
Yeah.
And the last thing is the calcium deposits. The thing with that is a controversial because a lot of doctors say that doesn't really diagnose coronary disease.
Okay.
It might be there, it might not be there, you know. So it's like nebulous, that situation there. And then you have the doctors that, hey, if I need to put 20 stents in you, I'm gonna put 20 stents on you because it's a procedure in and out. All right. Right now, that used to be the big moneymaker for cardiologists, from my understanding, and now is a TAVR. A TAVR is a trans-aortic. Let me see.
TAVR, we can look at it.
Yeah.
How do you spell it?
TAVR.
TAVR. Okay. Let's look for it real quick. See if we can get up to here. TAVR. You found it?
When was there? It's a transcatheter aortic valve replacement.
Transcatheter.
Yeah.
Aortic valve replacement.
So we're going to talk about that in a different episode.
That's cool. TAVR. Okay.
Yeah. No. TAVR.
So
it's R at the end.
So how do they call it? Like
transcatheter aortic.
No, but like how do you? Oh, you just call it TAVR.
We say TAVR.
Oh, you call it TAVR. Okay. All right.
Yeah. So that's something that we're going to talk.
So getting back to the Widowmaker.
Yes. So that was the difference between the doctors. Some of them believe on aggressive stent treatment, and some of them believe in a lot of prevention and not such invasive devices that can help the heart in some ways. I believe that the best thing is both.
So some of them believe more in a pre, and some of them believe like more on like a post treatment.
Yeah.
It's like a pre-treatment versus post-treatment.
Yeah, and in the industry, there are some cardiologists that are known to do a high volume of cases, and they're not always warranted. Now, I'm not a doctor, so I'm not gonna.
Right. No, you're just talking about the industry.
Yeah, this is just what I
you're
heard.
a nurse. This is the nurse multiverse.
That's what I heard of the nursing streets. You know,
in the streets. You're the streets.
On the streets.
You hear. You got your ear to the streets.
On the floor.
Baby.
That's what you hear on the floor,
streets, baby.
You know, you hear some things. You know, the nurses are always there. We're always present. So,
are you saying the doctors? Are you saying the nurses for the streets?
Nurses for the streets,
baby.
Yeah,
Okay.
Yeah.
All right. So, that's very cool. So, getting back, because I'm very interested in the Widowmaker documentary. What you're talking about. So,
you got to watch it and tell me what you think.
I will.
Okay.
But it's letting you feed my interest a little more.
Yeah. Let's do it.
All right. So the main discussion there is the implementation of the modern stent. Is that like the main topic of or is it like
the main topic is
heart attacks?
Is the Widowmaker situation, which is people would just drop dead.
Got it. From heart attacks, right?
From a heart attack.
Yeah.
And the Widowmaker is a specific vessel. They call it that because it happens very frequently, and is one of the most deadly things that you can.
What do you mean by specific vessel? Like,
so I'm not covering the coronaries and all the circulation that is in the heart.
Yeah,
so
I mean, you know more than I do.
Yeah, so when I'm talking about a specific vessel, is a vessel that is in the heart, in the heart muscle, and that vessel is giving oxygenated blood to the heart,
and
that vessel occludes, and the heart cannot beat anymore.
And that vessel is what they call the
Widowmaker.
Yeah. Interesting. Do you know the name of the vessel?
I will have to check.
Guess what?
It just makes me look like I don't know nothing.
You do know. Guess what? It's the Widowmaker, right?
We're gonna talk about
that's the name, right?
No.
That's how they call it. You mean the scientific name? So
yeah,
you can put what is the scientific name for the Widowmaker valve? Or?
No, it's either artery or a vein, but sometimes I get confused.
Okay. Cool. Are there any other documents?
So here we go. So the Widowmaker is the left anterior descending artery. Left anterior descending artery, which supplies blood to the larger front part of the heart. And that's known as the Widowmaker. Yes. There's other names for other arteries. One is RCA, which I think stands for right coronary artery.
That's Google. That's Google for you. Google for the win, baby.
Yeah, you can do it.
Google with the W.
It's just a message to anybody. It's okay not to know everything. Right. It's fine. We got computers in our phone in our phones. We can figure it out. Right. It makes me feel vulnerable because I'm not really in that place.
Don't worry about it. I have no idea. Like I do not know probably 1.5% of what you just talked about here. But
do you understand it?
I understood everything you said.
Okay.
It was very good. So you did a great job. Great job.
Awesome. Thanks for pumping me up.
Yep. All right. You have anything else to add up here?
Nope.
Right.
We pretty much cover everything. We are going to be having a assist device. I'm going to bring a guest that's going to talk about ventricular assist devices.
It's going to be what, next month? You're going to have that?
That's going to be in September 6th. We're going to be dropping it that week.
Well, we're probably going to be recording the 6th, but
yeah.
We might drop it the next week.
We'll drop it.
It's gonna be in September though.
It'll be dropped when the boss
drops. It's gonna drop when it drops.
Mm-hmm.
You're the boss, but it's gonna be in September.
Yeah, so we're gonna bring a guest on that. It's a person that I admire a lot. One of the best nurses I know, and one of the best teachers that I've had the privilege to work with. So I'm excited about having him in the podcast.
What is the name of that, by the way? The device we're gonna be looking at next month.
We're gonna be looking at ventricular assist devices.
Ventricular assist.
Yeah.
Devices.
So we're going to be covering balloon pumps. We're going to be covering ECMO, which is extracorporeal membrane oxygenator.
Okay.
We're going to be covering impelas. We're going to be covering tandems. We're going to be covering TAVRs, and also right and left ventricular assist devices, which is we know it as a RVAD. or a LVAD. We're going to be covering HeartMate 2, HeartMate 3, which is a type of LVAD. And we're going to also cover hardware, which is right or left. It can be right or left ventricular assist. So we're going to be talking about the important things there, what to look for. We're going to try to make it simple, like everything else we do, so people understand what these devices do. And that's it.
Sounds great. So guys, you can always like this video. You can subscribe to the channel, the Nurse Multiverse. If you're listening on Spotify, you can as well subscribe and follow the channel. That way you can always be notified whenever there's a new podcast coming up from the Nurse Multiverse, baby.
Boo, 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 boo.